Shall I start?
Please go ahead.
Yuvanam balam rashtrasya balam bhavati. The strength of the youth is the strength of a nation. The strength of our young anesthesiology members and their voice is the pride and asset of our esteemed body, the Indian Society of Anesthesiologists.
Welcome to the YUVA CLIP Clinical Practice Oriented Webinar Series for Practitioners, brought to you by Indian Society of Anesthesiologists National and the College of Indian Society of Anesthesiologists.
Good evening and a very warm welcome to all. On behalf of Indian Society of Anesthesiologists, it's my pleasure to welcome you to IC National Clinical Practice Oriented Webinar Series, The CLIP. Today, IC National brings the first YUVA CLIP session, a special program that encourages young anesthesiologists to showcase their work and ideas. Myself, Dr. Aradhana Panda, Senior Resident, PGIMer in Capital Hospital, Bhubaneswar, I and Dr. Surya S., Senior Resident from Jipmar, Puducherry, will be the screen coordinators for today's program. In this series today, we have an engaging panel discussion on the topic cancellation and postponement of surgical cases. This session will be moderated by Honorary Secretary, ISA National, Professor Dr. Sukhminder Jeet Singh Bajwa sir, and I request him to kindly share his opening remarks.
Thank you, Dr. Aradhana. I think we have got a very distinguished panel of the experts, the young experts at Mind, and it's always nice to be amongst them, and you feel yourself a very young. So that's a privilege to be part of this first YUVA clip, which is going live across the nation now. The concept of this panel discussion, the idea behind this YUVA clip is that how our young mind thinks, how they really grow up as anesthesiologists in this current scenario, in the current century, where everywhere the medicine has advanced to a different level. You take the anesthesiologist 4 decades back, whatever the syllabus they used to cover during their post-graduation, and now with the advent of so many gadgets, so much equipment available, so many new techniques have come, the guidelines have changed and evolved over the years. So these minds are always very young, knowledgeable, talented. And how the perspective has changed over the last few years or the decades, that also depends upon how they have imbibed the knowledge right through their postgraduate career. So idea of putting this theme is that many times, the anesthesiologists are being blamed for a postponement and surgical cases or even a cancellation sometimes, which is not true. Everybody of us knows because each and every doctor, they always try to work for the benefit and the safety of the patient. But somehow, certain times, there are few people who can take advantage of these armor, and right behind that screen, the patients do get suffer when their postponed surgery or their cases are cancelled for trivial issues. Here, in this panel discussion, which will be open to the audience also at the end, we'd like to highlight many such cases in our daily case scenarios, whether in the institutions or in the private practice or anywhere else, that how they get impacted with the decision making of anesthesiologist. So right here we are, and I request Dr. Aradhana and Dr. Surya to proceed from here so that we can introduce our distinguished panel. Dr. Aradhana and Dr. Surya, please.
Thank you, sir. Before we dive into the session, let's take a moment to introduce our distinguished panelists. Now, I am welcoming Dr. Karthik Devarajan to the YUVA CLIP series. He is an assistant professor in Annai Medical College and Hospital in Chennai, and his area of interest in regional anesthesia and difficult airway management and in pediatric anesthesia. Welcome, sir.
Next, I welcome Dr. Manisha Singh, consultant anesthesiologist at Horizon Group of Hospital, Thane. Her areas of interest are labor analgesia, obstetric anesthesia, regional and thoracic anesthesia. She has been awarded second prize and podium presentation at Association of Obstetric Anesthesiologists and Mumbai Anesthesiologists Society Conference 2016. She has presented a paper on World Anesthesia Day 2015 titled Anesthesia Management for Cesarean Section in Achondroplasia. Welcome, Dr. Manisha ma'am.
Next, I am welcoming Dr. Arun Pandian. He is a consultant anesthesiologist and he is a HOD for Department of Anesthesia and Critical Care in Erode Medical Center and also a secretary in Erode Society of Anesthesiologists and also a secretary in Lions Club International. His area of interest are critical care, general anesthesiology, high-risk patients, focus, ultrasound guided blocks, and also in leadership. He also awarded a ISA National Young Talent Award in 2024 and ISA National Public Awareness Award in 2024 and few other publications. Welcome, sir.
I welcome Dr. Vinita Munde, consultant at Godrej Hospital, KG Somaya Hospital, Mumbai. Her areas of interest are general anesthesia, regional blocks, and pain management. She has been a coordinator at Difficult Airway Workshop at Somaya Medical College. Welcome, Dr. Vinita ma'am.
Next, I welcome Dr. Anil Kumar Koduri. He is a lead consultant at Gas Freelance Associates and he is a medical director in Coromandel International and also a secretary in ISA Kakinada and also a founder of Perioped Academy app. And his area of interest in regional anesthesia and in focus. He also awarded a ISA National Young Talent Award in 2024 Patna and also a guest speaker at ISA National Patna, YUVA Dehradun and Andhra Pradesh State Conferences. And he is also a faculty in regional anesthesia workshop in Indore, BGM Mangalore and Mahavir Jain Bangalore. Welcome, sir.
I welcome Dr. Bhumika Savalaya, freelance anesthesiologist at Advaita Cancer Hospital and ICU Surat and Prish Multi-Specialty Hospital Surat. Her areas of interest are difficult intubation, regional anesthesia, pain management, and focus. She is a gold medalist in MD anesthesiologist, faculty at annual conference of YUVA ISA Dehradun, faculty at local CMEs organized by Surat Anesthesia Association. Welcome, Dr. Bhumika ma'am.
Next, I am welcoming Dr. Amrita Shashank. She is a consultant in Prakriya Hospital, Bangalore, and her area of interest in regional anesthesia, focus, and anesthesia for high-risk patients. Welcome, ma'am.
Next, I welcome Dr. Srishti Rai, third year PG resident, Prasad Institute of Medical Sciences, Lucknow. Her areas of interest are difficult airway, general anesthesia, regional anesthesia, and critical care. Welcome, Dr. Srishti.
Next, I am welcoming Dr. Prakriti Singh. She is a postgraduate resident, third year in R&T Medical College, Udaipur, and her area of interest in regional anesthesia, focus, difficult airway, and in general anesthesia. She also awarded Dr. T. N. Jha ISA National and State Level, National Level, and State Level Award in 2023, and she also won this second prize in Rajasthan 2023. Each of our panelists will bring unique perspective to the table, and I am sure we will have rich and engaging conversation. A kind information to the dear participants, kindly turn off the mic and if you have any queries, kindly place it in a chat box, will be discussed at the end of the session. Thank you. Now I am handing over the platform to our Dr. Sukhminder sir.
Yeah. Thank you, Dr. Surya and Dr. Radna for introducing our distinguished panel. I think people will be watching the youngsters now today, how they really conduct this panel discussion. I'm just going to help them only. What are the thoughts going into their minds and how the things really unfold in the coming 1 hour. So right now, I will start with the person, Dr. Kartik Devarajan. Dr. Kartik is a very young HOD. Previously, for some time, he remained as HOD, as a level of assistant professor at his medical college. So I know he must have faced many of the administrative issues when building a new medical college. When you're building a department, there are teething problems. So many things are there, apart from the clinical work. So it's pertinent that a person who's at just young age, who's handling the dual responsibilities of an administrative head as well as the clinical head. So he must have faced many challenges, especially when he had to cancel or postpone a surgery where he must be feeling that going ahead with the surgery may be detrimental to the patient. I mean, the pressure he must be facing from the lot of administrative heads as well as the clinical side on the surgical sides to deal with such pressures single-handedly and to manage it precisely is a tough job. So I just want to ask Dr. Karthik how he managed to balance between the patient safety and the surgical cases as well as running a smooth clinical unit of surgical, ortho, gynae, whatever you have undertaken at that time. Dr. Karthik, your views on that?
Good evening, sir. Am I audible?
Yeah, audible.
Yes. Good evening, sir. Good evening to everyone. First of all, I would like to thank Dr. Sukhminder sir and ISA for giving me this opportunity the first time as a panelist. The challenges which I have faced during cancellation or postponement of surgery. I would like to elaborate this scenario with two case scenarios. The pressure per se from the surgeon or from the management side, I did not get much because they were so co-friendly with us because I was the sole anesthetist. So my decision was the final. The pressure was very less from them. But however, the decision making on the case-to-case basis, whether to proceed or to cancel, it was very difficult, challenging for me because whether I can handle the case or not. So decision making was very much challenging for me. So among coming to the two case scenario, first one case I had to cancel on the day of surgery for patient safety, and another case I had to proceed. I had to take the challenge and I proceeded the case. The first case was 40-year-old male, the case of right tibial comminuted fracture, posted for open reduction and internal fixation. Um, Patient is a known chronic smoker and he is a known case of COPD and his PFT report was moderate obstruction was there. The rest of the investigation was within normal limit. So we had a plan to proceed the case under spinal anesthesia. We failed to intimate the patient under spinal during the PSC. That's what happened. So on the day of surgery, while getting a consent, patient refused to give consent for spinal just because patient had a myth that he may develop low backache after spinal anesthesia, and also he don't want to be awake, maybe due to our fear factor. He don't want to be awake during the surgery. So due to this reason, he insisted on general anesthesia, but due to his lung ailment, I considered uh, uh, it's not good for the patient to continue under the general anesthesia. So I told the patient to we are canceling. Actually, I tried to convince the patient, but patient was not convinced. So later, actually, I had to cancel on that day, but later I convinced the patient. Later, after 1 or 2 days, I think we took the case under spinal only after giving assurance. This was the case, first one. The second one was the 59-year-old male case. He's a case of right inguinal hernia, weight about 90 kg, planned for TAP. His investigation was with everything was normal, except that his mouth opening admitted only less than 3 fingers, around two to three fingers only, and his Mallampati was three. His Mallampati was three. So I anticipated difficult airway. Since I was alone, so I had afraid of whether I can proceed the case because we don't have a fiber optic bronchoscope for awake intubation. So I thought I can proceed the case or I little bit hesitated to give the case. But however, I proceeded. I took the challenge because I thought if I could able to ventilate, then nothing to worry. So I proceeded the case and I succeeded in intubation. So in these two cases, my point is to share whether to cancel or proceed with the case is should be on the case to case basis on patient benefit versus the patient risk. That's how I took.
Okay. So we get a very good message from here. That means even if you cancel a case for a patient safety or whatever factors are there, it's always pertinent to at least convey to the patient directly. rather than a surgeon or any other person explaining, maybe a staff or a technician explaining to the patient, the first hand communication by the attending anesthesiologist, it will really, boost up the confidence of the patient that it was not right. That's why it was cancelled or postponed. I think that is the message from the first case. And in the second case also, I think the way Dr. Karthik went in getting the case done, we should always be prepared for a difficult airway, even if we are doing it under a regional or under spinal. Such cases, because you may not be knowing that at what stage the surgery may get prolonged. If you are not putting it under epidural or spinal effect veins off, then you have to secure the airway. Or if some spinals get patchy or failed and you are not putting up the second time, which many people usually do, at that time, again, the airway management is going to be a big issue. So in these type of cases, it's always pertinent and prudent to at least prepare a trolley of difficult airway so that we can proceed with the case. Rather than just because if we are spinal is patchy or we should know we can't give the GA because the airway cannot be secured. So rather than getting sorry later, it's better to prepare for everything. So these are a very good messages from a young person who had the department of a medical college for a few months, and I think he really come out with the flying colors on the clinical and administrative side. So that's a really thank you, Dr. Karthik, for such an elaboration of the case scenarios. I can see my elder brother, Dr. Naveen, also joining the case, uh, this one, our panel discussion. So he can also give wishes before we move to the next question. Dr. Naveen.
Thank you, Dr. Bajwa. And I'm today very, very happy that you have started the YUVA Clip series exclusively dedicated to our young anesthesiologists across the country, the YUVA ASIANs, and heartiest congratulations to each and every participant for being on this particular platform and sharing your thoughts and inputs about a very practical issue which we all face daily in the institutes about the postponement of the case. I'll just like to say one thing. Once you are accepting a patient for surgery and conducting anesthesia, if you think that if this patient would have been my relative, whether I would have administered anesthesia and which type of anesthesia I would have administered, follow that thing on the patient. If you think that if the patient would have been my mother or my brother, I would have chosen a different anesthesia technique, or I would have done this particular test before taking up the patient for surgery and anesthesia. So bottom line is treat each and every patient like your own relative. And it is rightly said, it is just another anesthesia for you. You daily conduct 7 to 8 anesthesia for patients, but it may be the only anesthesia experience for the patient. So make it as safe, as fruitful, and as pleasant as possible. God bless you all. You are the future of ISA and future of India. And many of you will be administering anesthesia to most of our age group. So your teaching and training is very, very important. And I can see, Dr. Bajwa, I'm very confident some of these will be sitting in our chairs also in near future. So we are just a phone call away. Anytime you have any query, any problem, you can contact the Secretariat 24/7. Dr. Bajwa and his team is working. And I also congratulate the team behind the preparations. A particular event takes weeks and weeks of planning and execution. So God bless you all, and please enjoy the academic series. Thank you very much.
Thank you, Dr. Naveen, sir. Dr. Naveen, our president-elect and going to be the president next year. So it's a good encouragement from him and take-home message from his wording is treat every patient your relative. So the postponement and the cancellation become much more easier to handle that issue. Thank you, Dr. Naveen sir, for this wonderful, encouraging messages to our young minds. So moving to the next question, I will like to another person who has been very dynamic, working as a secretary of a city branch, won so many accolades and awards, and doing so much of the clinical work, administrative work, sports, and extracurricular. So he never tiring efforts are always there. So I'm talking about Dr. Arun Pandya. He's a secretary of a road city branch, and he's managing a 750-bedded hospital as a young HOD there. So my question to you, Dr. Arun, is that if you, during your duty hours, you encounter a 75-year-old, a geriatric, diabetic and hypertensive patient coming to your emergency with a fractured shaft femur and a loss of almost 1.5 to 2 liters of blood, and with injury duration of around 4 to 5 hours, I think still within the 6 hours, and a component of subarachnoid hemorrhage with a GCS of 11. What now, and how you proceed in this case, whether you want to cancel one surgery or you proceed with both the surgeries? So what is the dilemma in these type of cases you face daily?
Good
Dr.
evening,
Arun.
good evening all. My sincere thanks to ISA National and my beloved elder brother, Dr. Sukhminder sir, ISA National Honorary Secretary, and Dr. Naveen sir. Now, moving on to the case, once I receive such a patient, my protocol will be as per ATLS. Initially, airway assessment along with C-spine, cervical spine control. If the airway is patent, then I will just clear the airway and maintain the oxygenation to a saturation of 94. Assess breathing. If the airway is not maintained, whether secure the airway with the endotracheal tube according to modified rapid sequence induction with manual inline stabilization of cervical spine. Once the airway and breathing is secured, then about either volume control or pressure control ventilation, both equal the same, nothing is superior. Moving on to circulation with hemorrhage control. If it is an open wound, resuscitation will help only if the hemorrhage is controlled. Since this is a shaft of femur fracture, it is not a compound one. The maximum what we can do at the bedside to control the hemorrhage is traction, either the skin traction or the pin traction. Following which, secure the large bore IV cannulas, get blood samples before even starting the fluids, not diluting the sample. Once you collect it, basic samples with coagulation profile, then you start resuscitating with warm, normal saline or ringer lactate, isotonic fluids. I will try to avoid colloids, especially albumin in case of traumatic brain injury. And once you resuscitate with 1 to 2 liters of initial bolus, check for the response. If the response is good and the vitals come back to near normal, then the blood loss is okay with the resuscitation and you might not need more amount of blood or more amount of fluid or operative intervention to control the hemorrhage immediately if the response is good enough. If the response is not good enough or if the response is transiently good enough, then it worsens. Then it indicates there is an ongoing blood loss. You may need higher amount of fluids or higher amount of blood, or operative intervention is high likely to control the bleeding. This is how, in this case, circulation will go. Once the circulation is stabilized, then you search for disability. Expose the patient, take preventive measures for, once the disability, assess GCS or AVPU, alert verbal pain unresponsiveness, any scale. If this patient has a GCS of 11, so and the airway is patent, then no need for assess GCS frequently. If the GCS is low, secure airway and put on ventilation with a good amount of sedation. Then expose the patient and do a head-to-toe examination. Take care to prevent hypothermia. Then head-to-toe examination and secondary survey. Get the drug histories during the secondary surveys, history as well as clinical examination overall. Once this is done, since this is an SAH, immediate surgical intervention may not be needed. Try to resuscitate to balance between organ perfusion and the risk of rebleeding or the bleeding in the brain increases. Try to balance this with a map of around 70 to have a cerebral perfusion pressure of 50 to 60 to 70. So that will help in maintaining the cerebral perfusion. Once that is done, after 8 hours, you can do a repeat CT brain with an angiogram to rule out AV malformation or aneurysm. Once that is done, you can plan a elective femur fixation 12 to 24 hours later under GA. That's how I proceed this case.
So there was the other attached to it, the dicey part was the hypertensive and the diabetic. That again will dictate the choices of fluid in this case. And rightly said, I gave you the option of 4 to 5 hours because any surgery coming within 6 hours, I think, always likely to operate. But the component of subarachnoid hemorrhage, how will it progress? If the GCS11 is there, I think it has some impact on the brain. But there is some the injury to the parenchymal tissue. There some axonal injuries also there. That may be the reason for the loss of consciousness or little bit obtunded response from the patient. So that you cannot ascribe entirely to the subarachnoid hemorrhage, which may have caused the GCS to down. So with the high hit from the vehicle, when the coop injury or the contra coop injury, you may get certain type of axonal injury component. So definitely in these type of patients, the geriatric patient, the reserves are very low. It's always better to resuscitate. Surgery will not prevent the life of the patient. Yes, the hemorrhage is there already that when the wound is, I think, closed with the 1.5 to 2 liter blood, estimated blood loss is already there in the thigh compartment. That itself acts as a, tourniquet that will stop the further bleeding in those cases. A good traction at this stage maybe a much, much better lifesaver. So it is not a cancellation. It's not a postponement. It's for the safety of the patient, we have to take a decision. And at this stage, most pertinent is to involve the orthopedician as well as the neurosurgeon along with you. You discuss at length with them that this is the scenario. If we're going to operate, the tap may open and we may lose the patient on table also. So it's better to resuscitate. It's an old geriatric patient, the geriatric anesthesia, it's altogether a challenging situation. And on the brain part, I think it's quite obvious that we have to monitor it seriously, whether the size of the subarachnoid hemorrhage is increasing or sometimes what happens in the initial injury, the brain edema lessens and the conscious level also improves. So it's better to wait and then you get the case done as soon as you feel it's stabilized. And in the meanwhile, do arrange the blood, the plasma, the platelets, everything should be in the ratios, whatever has been recommended as per the guidelines when such patient comes to the good institution. And if they come to the periphery, I think it's better to refer to the good institution rather than risking the life of the patient by taking everything in our hand. We may not be having those facilities with which we can revive this patient. Yes, Dr. Arun, thank you very much. So did a wonderful job in managing. I think you must have managed these cases so many times. So it's that's how your experience was speaking when you were telling about this patient. Thank you, Doctor.
Thank you.
And now we coming to the next panelist. He is another dynamic personality, secretary of a city branch, equally involved in the academics, right from the Monday morning, evening classes of the postgraduates. So he has been doing a lot of academic and non-academic works, very enthusiastic. I'm talking about Dr. Anil Podri from Kakinada, Andhra Pradesh.
Thank you,
So,
sir.
Dr. Anil, I just like to ask you one thing.
Sir.
It's a very normal scene, a normal scenario where a PSC fit patient, suppose I'm taking a very simple case, a laparoscopic cholecystectomy. The patient in the morning arrives on the OT table, and when you take a first reading of the blood pressure, although it was a hypertensive patient, but it was a controlled with antihypertensive. You may have given the morning antihypertensive also. And suddenly you get a reading of 190 or 200 systolic and 120 diastolic. So what is your immediate response to such a reading and how you're going to plan whatever you're going to do? Tell me from here.
Yes, good evening, sir. First of all, I was very honored to participate in this YUVA Clip series, and I was very thankful to you, sir, for giving this opportunity. Sir, hypertension is a common challenge we all anesthetists will face in this OT, but the patient who is optimized before and PSC given fit, if I see that type of patient having 190 by 120 on the OT table, First of all, we must think whether the patient is having white collar hypertension or if the patient is not compliant to the medication. That means he must not take in the medication on the morning, if even we told them to take, or sometimes whether it is really an hypertensive emergency or urgency. So before these things, we must conclude whether the reading is correct or not. So we must recheck the reading with a manual cuff, or sometimes we in some OTs because of short cuffs, it will give an overrated rating. So we must recheck with another monitor, or we must recheck with the manual monitor. So if at all it is on a and then we should assess the symptoms. If the hypertension is associated with any symptoms, such as having any headache or any dizziness, any something other than neurological symptoms, then only we will should consider it is an hypertensive urgency or an emergency. Otherwise, we must it will be like an white collar hypertension, because the patient may feel anxiety or stressful, so that his BP raised on the table. Before it will not, it's not like that. So we must reassure the patient first of all, and we should give some benzodiazepine or like midazolam for some time, and then we should wait for some time and again recheck the BP. Our aim to start any case is having the BP of around 160/100. It is better to start the case, because to avoid all the perioperative complications like stroke and MI and everything, or even hemodynamic instability intraoperatively, you can prevent. So before deciding whether to postpone or to proceed the case, we must risk stratify, sir, what type of hypertension it is. Whether it is a white collar hypertension, or it is an uncontrolled chronic hypertension, or it is a hypertensive urgency or a hypertensive emergency. If at all it is a hypertensive, it is white collar hypertension, it will reduce if we reassure them. Or if at all it is an uncontrolled chronic hypertension, the patient is having hypertension from a long time, we can proceed the case and we can increase the BP intraoperatively by giving short-acting antihypertensives and all. But if the patient is having hypertensive urgency, that means the patient is having like this 190/120 without any symptoms, it is better to reduce the BP to 160/100 gradually, and we should wait for 3 or 4 hours, and then we should proceed the case. So in these 3 to 4 hours, we can give a short-acting antihypertensives like labetalol or some nitroglycerin in NTG infusion and all, and then we must proceed the case. Or if the patient is having any symptoms, we just postpone the case, like symptoms like chest pain or dizziness or headache. We must declare it is a hypertensive emergency. We must postpone the case for the patient's safety. We must optimize the patient. We must refer the patient, and then we must go. Even though in hypertensive urgency, if there are no symptoms, if the patient is asymptomatic but having around 190/120, and even after giving this type short-acting antihypertensives, the BP is not reduced, then also we will postpone. If the BP is reduced to 160/100 only, we should proceed the case in the case of hypertensive urgency and patient is having signs such as LVH or chronic kidney disease, or the patient is having any history of CAD, and also for the safety of the patient only, that means to reduce the perioperative complications like stroke, MI, or hemodynamic instability or excessive hemorrhage in the intraop. So it is better to postpone if the BP is not reduced to 160/100. So my conclusion is, sir, first of all, we must reassess the patient, reassess the BP, whether it is correct, accurate, or artificial reading. And second thing, we must differentiate from the hypertensive emergency, real hypertensive emergency or a white collar hypertension. And third thing, if it is a hypertensive urgency without any symptoms, we should reduce the BP to 160/100, and then we should proceed the case. And if there are any symptoms, we must postpone the case. And better for patient safety, we should reduce to 160/100, and then only we will proceed the case.
Yeah. So the message which carries along with this discussion is that even if it's an isolated reading or the first reading it comes to on the table, and with a history of the well-controlled blood pressure previously with the PSAP, that means the anxiety component is a more likely cause for these patients. And sometimes what happens when the anxiety is there, it takes some time. You take some time to get it down. It's not that easy that just injecting the benzodiazepine, we will be able to achieve our target. It takes time. Moreover, the cuff sometimes the cuff with which the BP was measured in the wards or in the PSC room may be different, and here it may be different. The electronic monitor, you cannot depend upon them every time. Sometimes they give a false reading, the method of tying the cuff. So many things are there. It's better to take off the cuff and bind in the next arm, the other arm. You try to take the BP from both the arms, that's always advisable. Yes, if the BP comes down 15 to 20% from the whatever the first reading is there, that means the BP can be controlled under the normal circumstances. Yes, symptoms are there. I think with this very one reading, the symptoms may not appear sometimes. The symptoms may take longer time. If the patient is a chronic hypertensive, sometime with the chronic as well as anxiety component together, they both had. So whatever we are going to do with the where you are going to give midazolam or you give some time of a little opioid mixed with opioids to bring it down, or you can use the short acting the labetalol or esmolol, whatever you can do to bring down. If it's not coming down, definitely you have to search for the causes for this high blood pressure because you are going to get carbon dioxide also,
Yes,
and
sir.
you are going to have the hypertension, more hypertension also in the running when the case will be running. So if the BP comes down, I think we should go ahead with the case. It's not just, I think 160, 100. I think that's we will keep a percentage. We will give a percentage. If it's a 15 to 20%, it's come down from the readings. I think it's well controlled. And when the patient will be under anesthesia, you can have a more control of blood pressure.
Yes, sir.
Dr. Karthik, you want to add something?
Sir, I would like to ask one question, sir. Does anxiety increase the diastolic blood pressure also, sir? Because in this case, it's 190 by 120. So usually anxiety causes systolic increase in systolic only. So I have a query in this.
Actually, what happens with the patient having both the components, the chronic hypertensive patient, well controlled on those things. So what happens with the anxiety? It's more about the pulse pressure, the difference. That is very, very important part. The pulse pressure varies widely in the hypertensive and the anxiety component is there. So first of all, we have to correlate the reading in the ward, whether it was 100 or it's 120 now. It's a basic, the systolic reading. What was the systolic reading in the ward? If I think it was a controlled, the well controlled must be around 130. So from 130, it has risen to almost 190. That is too much of a percentage. And from systolic 90 to 120, just 30 millimeter of rise. So the percentage may not match each other. That's definitely the component is there. But both can rise because the sympathetic is the autonomic nervous system which gets activated during anxiety. So both the components can rise in that matter. So that's not an issue. But the more importantly is that if the blood pressure comes down with your sedatives or your opioids, I think it's better to proceed with. That means your anesthesia is going to be effective because this is the common way our surgical cases get postponed and cancelled in many of the OTs that the BP is higher, it's going to affect. But that BP, the person may have that type of BP in so many places that so many incidences must have occurred during his or her lifetime. So I think if any slight control, if you can control the blood pressure with your just injecting the IVs, opioids and sedatives in a minimal doses, I think that's a good sign. We can go ahead with that surgery. So ठीक I think the message is clear that these type of situations are encountered many times. We should be prepared to lower the BP there rather than postponing the case because we consider that our relative is also lying on the table. So what we are going to do.
Yes,
So,
sir.
and the vigilance, your eternal vigilance during the entire surgery is very, very important. Keeping the eye on the pressures of the, the insufflation and everything, the speed of insufflation, those are very, very important to control the blood pressure. Thank you, Dr. Nil. That was a very good discussion from your side. Now, I'm coming to another dynamic speaker, Dr. Bhumika. She working as a corporate setup or a small small corporate or a freelancer, and she is doing the almost private cases, and there's a difficulty to always to postpone in those circumstances. But even in the setup she's working, if I say that she encounters the case of a commando, post-operative commando, okay, that is I think must have done for the carcinoma tongue, and then lands up to the OT for elective surgery after getting a PSC clearance and airway evaluation. And in the operation theater, you are unable to secure airway even with the advanced gadgets, including the second and third generation LMAs and video laryngoscope, as well as a fiber optic bronchoscope. how will you proceed? And if you are the senior most in your institution and hospital, that you are not able to secure the airway, and in both the circumstances, whether elective surgery or emergency surgery, so it's a dicey situation for you. Dr. Bhumika, please.
Yes, sir. Uh, First of all, a very good evening to all my seniors, and I would like to congratulate um, Dr. Naveen sir, Dr. Hina madam, and thank you so much, Bajwa sir, for giving me this opportunity to join the YUVA Clip series. So, starting towards the case discussion. So, first of all, let's discuss the emergency situation. What if this patient comes in the emergency? So, first of all, yeah, this is an operated case of commando. So there would always be in my mind that it can be anticipated difficult airway anytime. Rather, though it's mouth opening is good, there is a good MP grading. Then also going while doing laryngoscopy, it can be difficult. So it should always be in our mind that if a patient is operated for oral CA surgeries, our difficult intubation trolley should be always ready by our side. And uh, uh, in this case, we have uh, uh, tried that uh, patient is ventilating enough or not. So if patient is ventilated enough, then we can wait for the uh, uh, patient to get awake. Our first priority in such situation should be the patient safety. That there should be no hypoxia and there should no any vital um, uh, and so in this case, difficult intubation trolley is there. We should ask for a call for help. We should one another anesthesiologist. We can ask for help. But if surgery we cannot postpone or we cannot delay, we are always ready with the cricothyrotomy and the tracheostomy tray as well. So while maintaining the ventilation and the oxygen saturation level, we can call for help by our surgeon who are all well trained to do tracheostomy. And in my setup, I have done one thing that I have made one small gadget for the emergency cricothyrotomy so that at least I can ventilate patient in case of cannot ventilate and cannot intubate the kind of situation. In which what I have done, I have taken one thick gauge needle, one 2 cc syringe and a connector. So while my staff is preparing for the cricothyrotomy or a tracheostomy or other help is coming, I can insert directly to the trachea that gadget and I can ventilate with the ambu bag. So that thing I have kept always ready. And meanwhile, that should be always be in our mind that we can use supraglottic airway devices, eye gels for the ventilation. If patient is not ventilated enough with the mask, we can go for the supraglottic airway devices.
Dr.
And
Bhumika, I have already told that we have tried everything, not
yes,
able to do with the LMA's third generation even. And
yes, sir.
then we
So
have used the video laryngoscope and fiber optic also, not able to visualize the airway. So there is a two option between elective and emergency. Now, on both the side, it's your decision. You are a
yes,
senior most. You're a senior
yes,
most.
sir. So in case of emergency, I would like to call my surgeon and while patient gets awake from the surgery in the private setup like where I am working, we need to explain the patient's relative also. So in here the case is emergency, so we will not wait for that the consent and will directly go with the tracheostomy will do the while maintaining the airway and oxygen level, will go with the tracheostomy and will go for the surgery in case of emergency. And
I think
in case,
we got the message now. I think I will explain it further for you. See, a senior most person, as a young senior most person in the hospital setup is always very, very tough on you. So because you cannot call help for a senior person here. You have told one thing very good in the beginning that first of all, when are you going to get the case done? If you have evaluated the difficulty, where you have already prepared with the video laryngoscope and all the syncricothyrotomy, tracheostomy, I think the first and foremost is to take a consent that if it's a emergency surgery or even for elective surgery, that on the table, if we land up in a situation of cannot intubate, cannot ventilate, because already it's a high risk anticipated difficult airway. So always take a consent from the relative that in case we are not able to ventilate or intubate such patient, we may land up in the invasive airway management. That consent is very, very important in the whether you're going for elective or for emergency surgery. Now, on the table, if you are able to ventilate the patient, if they're able to ventilate the patient for elective surgery, I think it's better. If you are not able to secure the airway, you can awake the patient. You can make the patient awake. Okay, that is the best way to go forward for the elective surgery. Yes, definitely. If you have taken consent and the surgery is emergency, you are not able to secure. Even with one of the anesthesiologists also accompanying you, may not be able to access the airway. It's always better to have a surgical airway because that is going to be the life saving. On the other side, that depends upon which emergency you are encountering. If it's life-threatening emergency, it's better to go for the tracheostomy. Otherwise, for a surgery which can be manageable with the time or duration, getting the patient awake, I think those surgeries can be postponed, whether it's elective or sometimes semi-emergency, which may not be requiring a life-threatening to the patient. So in that case, I think rather than elective tracheostomy or emergency tracheostomy should not be the choice. But in case you are trapped, the surgeon you must be prepared. It must be ENT surgeon or a general surgeon who is good in ensuring the tracheostomy. I think that must be standing on your side. You can always request, even in whatever setup here. So that is, I think, is the way I think. Will you agree with me for that thing, Dr. Bhumika?
yes, yes, sir, definitely, sir.
I think this is the approach in these type of cases. Yeah, Dr. Vanita, you want to say something? Unmute yourself.
Sir, as soon as there is a call for us, what we can do is we can ask for a fellow anesthetist standby prior to going ahead with the case, as well as a
Definitely.
surgeon or a ENT specialist standby so that they are aware and they are ready. It is not that we have started and then we ask for help,
Yes.
which will be detrimental because that minimum time, whatever buffer we are getting, that will be very crucial. This is what I
Yeah.
want to add.
So this is the scenario. Thank you, Dr. Vanita. This is a scenario where the anticipated difficult airway is there. Where the unanticipated difficult airway we encounter and surgery is of elective, I think it's always better to make the patient awake and rather be safe than sorry later on because the patient's safety is your priority. So, and even the surgeon, even every part of the country and every surgeon knows that this airway problem is the big, big problem and may land up as in problem. And so they will also agree with you. I think everybody is a human here. It's not a matter of the anesthesiologist or a surgeon having a different opinion here. But when the problem is there, so everyone also knows that we have to agree on one solution, one compromise. But documentation of such cases is very, very important. That's the message. Thank you, Dr. Bhumika. It was a tough question for you. I know it's a very difficult. And in the scenarios also, in the private setup, it's more difficult actually clinically rather than just theoretically. It's very difficult. So thank you, Dr. Bhumika. Now I'm moving to Dr. Vanita. She has given a good advice on this case also. Dr. Vanita, now I will just want to ask you that many times you see a patient with the history of cardiac bypass surgery or a stent placement and coming to you for the elective non-cardiac surgery. And when you encounter such patient, then your first thing comes to your mind about the cardiac condition because these are very dicey, especially after the COVID. We have seen the number of the cardiac incidents happening, especially during marathon also. Even the fittest of the people are also suffering from the cardiac arrest like that. So with no cardiology backup, no cardiologist by your side, So how will you like to take up this case for surgery, for non-cardiac elective surgery?
So, sir, first of all, thanks to Sukhminder, sir. This is my first time being a panelist. So, thank you, sir. Thank you, ISA headquarters. So, if such patient comes to me, first is I will do a proper, thorough preoperative evaluation. When was the CABG done, or when was the PTCA done? What is the current cardiac condition of the patient? Like a thorough tests, whatever diagnostic tests, routine as well as extra tests which will be required, like a pre-op 12-lead ECG or 2D echo. Also, what was the last 2D echo report of the patient, and how has the heart progressed? Whether the ejection fraction has been the same, it has reduced, or everything. Pre-op counseling as well as proper communication with the cardiologist, with the surgical team, as well as patient and the patient's relatives. If the surgery is a low risk surgery, for example, if it is an endoscopy or if it is a cataract, such patients coming to a setup wherein there is no cardiologist, what I will do is I will talk to the patient's cardiologist regarding patient's current condition. I will do a thorough evaluation of the patient, and then I will take up this patient if it is a mild surgery or a low risk surgery wherein the risk of complications, post-op, peri-op, cardiac complications are less. For example, that it is a upper GI endoscopy, it is a cataract surgery, then perhaps I will go ahead with the surgery. But if it is an intermediate grade surgery or if it is a high risk surgery wherein I am expecting major fluid shifts, or if it is an emergency surgery wherein I am estimating there will be major cardiac events or cerebro-renal events, then in such scenarios, I will be careful to assess whether patient's cardiac condition is suitable or not. If it is an intermediate risk surgery and patient's ejection fraction is good, I have spoken with the cardiologist, patient's cardiologist. Cardiologist has given a go-ahead signal. And if it is a peripheral, like a limb surgery, wherein it can be done under blocks, under regional anesthesia, then I will go ahead with the surgery, explaining the risk totally to the patient as well as relatives, as well as the surgical team. And then I'll go ahead with the surgery. But if it is a major surgery wherein there is a higher chance of adverse events, then I will ask the patient, the relatives, as well as the surgeon who is involved, that it is better to take the patient to a better setup wherein there is a proper ICU, proper cardiologist who can be on standby to go ahead with the case. So it all depends on what is patient's current condition, how long was the CABG or PTCA done, as well as what the cardiologist has advised from his side. So it all depends on patient's current cardiac condition, as well as what is the type of surgery, as well as what will be the duration total of surgery and what are the complications associated with the type of surgery. And one more thing, sir, pre-operate, even if it is a low-risk surgery, I will see that pre-operatively patient is optimized. I have spoken to the relatives regarding the risk associated, the risk stratification. So we as a team have to sit with the patient and relatives, the surgeon, me, and the administration, that this ABCD can happen. We have to be ready. We have a ICU backup wherein we can keep the patient over there. And most important thing is counseling and being transparent with the surgeon as well as the patient is crucial in such scenarios. So it all depends on the logistics, the staff availability, the ICU availability, the type of surgery, duration of surgery, and the patient's current clinical condition and the
Yeah.
labs.
Yeah, thank you, Dr. Vanita. I think it's a very elaborative discussion. The first of all important when these patients come, they come to you. You always take a history of the duration of the surgery, when was it done, and for what it was done. That's very important. That how was the functional residual capacity of that patient and the cardiorespiratory reserve, basically. Similarly, for the stent insertion also. With the stent insertion, patients are usually healthy, but sometime during the obese patient, there are stent insertion. So comorbidities may be there. Second is the type of drugs the patients are taking for the currently, whether for the CIBG or for the stent insertion, what type of drugs they are using, antiplatelets, what antiplatelet they are using. So how to stop, when to stop, that is another issue. I'm not going to discuss that because everybody knows the guidelines for that. The type of surgery is very important. As in the beginning, I told that there is no cardiologist in your setup. Definitely, you must have depended upon the cardiologist who provided the services to the patient previously, whom the patient used to visit there. So whatever the cardiologist must have written in his report, I think that should be taken in a good manner. If the surgery is a major one and you have no cardiology setup, I think it's always better to refer the patient because you may not be able to handle that thing because those are the very, very important part. So by the minor surgeries, intermediate surgeries, I think you can go ahead with that after taking appropriate precautions, just following all the protocols like first of all evaluation, the pre-anesthetic evaluation, the cardiology opinion you have taken, then stopping the drugs according to the guidelines. Okay, there is a lot of controversy in that the clopidogrel stopped 5 days or 3 days or 7 days now. So a lot of evidence is coming up on that also. So I think when the surgery is major, it's always better when the cardiologist is not there in the setup, don't do the surgeries because patients' relatives are very, very much aware because they must have spent a lot of money on the CABG. They must be knowing almost every cardiac ailment and they know the importance of the cardiology. It's always better to this one refer the patient to a center where the real setup is there. That is, I think, good. The rest of the surgeries, I think you can undertake. Yeah, please. Further, you want to say something?
Sir, here I want to discuss two case scenarios in a brief way.
Dr. Vanita, we have a very short time. They are long cases or just one or two
No,
lines?
no, no. One or two lines, sir.
Yeah, okay.
First case was patient were there. This was in a proper hospital with a proper setup and a cardiologist standby. Patient was not having CABG, but he was having a right fascicle block, right bundle branch, and left anterior fascicle block. We had explained the patient that patient can go into total complete heart block and he might require pacing. So that patient was for lab coli, sir. We took up the patient as soon as the pneumoperitoneum was created. Patient went into complete heart block. We had the cardiologist standby. He came, he put up a temporary pacemaker. Then on the second day, a permanent pacemaker was inserted. And after 2 days, patient was taken up again for lab coli and it went on successfully. This is one scenario. Second scenario is just yesterday I did a case in a nursing home, sir, wherein CABG patient, 52-year-old post CABG on 26th of December, that patient had come with wound infected, sternal wound was infected for debridement and back dressing. So there I explained everything to the patient, the patient's relative, a high risk consent was taken. I gave minimal sedation, sir, and the case was done.
Okay.
So these are two scenarios, sir, wherein I thought that I could go ahead and do it. So these are the two scenarios.
That's the message we got from you is that evaluate each patient on an individual basis.
Yes.
Evaluate your skills, your confidence, your competency, your setup, your surgeon's competency. All these are very, very important to evaluate before going for even intermediate or a major or a minor surgery. I think this is the message from your case scenarios. Thank you, Dr. Vanita. It was a very, very good discussion and good case scenario elaboration. Thank you, Dr. Vanita. Now, moving to another dynamic young anesthesiologist who is a freelancer full of confidence, Dr. Manisha from Thane. Dr. Manisha,
Yes,
I'm just
sir.
asking you one thing. If you must have handled so many of obstetric cases in your life, an emergency obstetric case with a very difficult airway. I'm not going to say what difficulty means. Difficult airway means must have written on his file on her file also that she must have undergone some difficult airway procedure previously, and she's coming for emergency LSCS. And unfortunately, you land up with a failed spinal. This happens to me also, to everyone also. So how are you going to proceed in this case with a difficult airway now, failed spinal?
Yes, sir. Thank you so much, sir. First of all, it's an honor being a part of this program. Thank you, Vajwa sir, Madhuri madam, for arranging this. And to go ahead with the case. So as you've already explained, it's an emergency LSCS with difficult airway, and I land up with a failed spinal. I would just like to elaborate on failed spinal. The best way to handle a failed spinal anesthesia in an obstetric patient is like how we anticipate a difficult airway in an obstetric patient. It is similarly, we should anticipate a failed spinal also, because all obstetric patients are difficult patients for giving a spinal anesthesia. Because of technical difficulties, they don't give us adequate positioning because of the pain and anxiety. There is obesity, there is edema, there is severe lumbar lordosis. So all these technical problem give us a hint that we can land up in this situation. So always anticipate and be prepared. Being prepared means I will have a backup for general anesthesia ready. Even if I'm going ahead with a spinal anesthesia for any obstetric case, all the backup for GA provided, the machine, airway equipments, difficult airway cards, suction, laryngoscope, everything should be ready in case of these situations. So a certain point where we generally should be taken considering before giving anesthesia. One is, I said, anticipate that it may be failed spinal anesthesia. So we be more careful. When we are being more careful, we avoid it. Second is adequate volume should be taken considering the stature of the patient. Approximately 10 to 12 milligrams generally suffice for an average Indian pregnant patients. And if we are anticipating it is a redo or a previous LACS or previous two cesarean section, and we anticipate that it is going to be a prolonged surgery, then always it is better to add some additives. Or if a junior or somebody fresher surgeon is doing a case and we anticipate it's going to take longer, additives always help. Now, in our scenario, whether it is a failed spinal pre-operatively, where before starting the surgery, when we assess the level of surgery and we come to know that there is absolutely no anesthesia attained, there is no loss of sensory dermatomes and the motor level is adequately intact. So now it all depends on the distress situation, emergency situation, whether the fetal distress is there and we don't have time to go ahead with another shot of spinal anesthesia. The gynecologists are not allowing us to make the patient sit again and go ahead with this. In this scenario, of course, then we'll have to proceed with general anesthesia. And we had already prepared with the general anesthesia, set up difficult airway, everything was already ready. So before starting with general anesthesia in these cases, always I would like to call someone for help. This call for help may be anyone, a trained staff who's been with you, a trained technician who knows how to handle difficult airway situation, or a colleague or a senior. Anyone, second hand is always helpful. So call for help is always there. A good suction, good airway equipments and everything. I'll go ahead with general anesthesia. And then these patients should always be considered full stomach. So back of the mind, we should be ready for rapid sequence induction of these cases. Then going ahead with the anesthetic agent is the regular induction agent of choice is propofol followed by scoline. Fentanyl generally we tend to give it post delivery of the baby, and maintenance of O2 air and sevoflurane. Now, second point is this was when I don't have time to give the spinal again. But there are certain situations where we can go ahead with the second shot of spinal anesthesia. And this time again, we need to assess the patient again completely, whether this was absolutely no spinal effect or a partial spinal anesthesia, where there is loss of sensory at around T10, T8, but not adequate to go ahead for the surgery. And there is some movement of the feet, but no raising of the leg is present. So this is partial. Now, when we go ahead with the now existing partial anesthesia is present and we go ahead with the second shot. So the dosing should be a little less than what we have given before to so that we don't face with a high spinal or a total spinal effect. And additives generally should be avoided in the second shot spinal anesthesia. And if at all, then we can proceed. If we have the chance to give a second shot, we can go ahead with the second shot and then go ahead with the surgery.
Yeah. Now, I think very well practically experienced thing you have deliberated upon this case scenario.
Another factor which we face in our day-to-day practice is sometimes So this is a pre-operatively which we have already diagnosed that is a failed spinal. Sometimes what happens is we start because we are in a hurry and the surgeon checks the dermatome level at T10 and say, "Ha, level aa gaya, level aa gaya," and we tell, "Okay, start the surgery." But once they start, adequate level is not achieved up till T4 or T5, which is a good adequate level to start do a cesarean section, and then the patient starts complaining of pain. There is already incision has been taken, and then the patient is non-compliant, and there is pain, and then again we are stuck in a scenario as to how to go ahead. In that again, it depends at what surgical step we are stuck in. So if the surgeon has already taken the incision, subcut and muscle, everything is done, and he's at the uterine incision, uterine just has to take the uterus incision and take the baby out. To tide over that crisis, generally most of the time we can, go get away with sedatives, with analgesic and mask holding, and we can help deliver the baby at least. Because that time, if the uterine incision is taken, we cannot ask the surgeon to stop and then we go ahead with GA, put in the tube, and then we proceed. So that time, mostly mask holding with fentanyl shot of 25 to 50 mics. Ketamine also helps, 10 to 15 milligram ketamine helps at that time. And we can help deliver the baby. But if it is just before the uterine incision at the time of muscle and subcute, and if the patient is in severe pain and adequate level is not achieved, we should generally ask the surgeon to wait and watch. For another 2 to 3 minutes, we can wait and watch if the spinal level is ascending. If we feel that it is not and the patient is complaining of severe pain, I think we should accept it as pain and not let the patient suffer throughout the surgery, because it is harrowing for the patient to go through such trauma. And they remember. Generally, they come to us also. If it is a previous LSES, they too tell us that we were aware, we were having pain. So at that situation, I always feel that we should go ahead with GA. And if we have the setup for a GA, we have help, and we feel that it is not going to be a very difficult task to put in a tube to that patient, we should go ahead with GA and get the surgery done.
Okay, so that was a comprehensive explanation of the case scenarios at what stages we are having the failed spinal. Definitely, if it's previously, if it's I think the surgery has not started, even I will also recommend. I have also gone many times for a second spinal, whatever the surgical distress of the fetal distress may be, because mother safety is more important at this stage. So if the surgery has not started, I think you always give at least take 2 3 minutes, because invariably in all the pregnant patient, because of that compression of the pits and plexus, the venous plexus, the effects come very fast. So if it's not coming in 2 3 minutes, that means it is going to be dicey. And I'm not going to go check the drug, which expiry drug, because those have to be checked beforehand when you are injecting the drug. That is our duty. And temperature of the drug also is better to always have, even in the winter season, just tell the technicians to at least rub the vial in his hand, I think, rather than just feeling the cold solution, putting that to the spinal, which may take a little longer for effect to come. Yes, when the incision is there, you cannot repeat a spinal. That's for true. Now, this case may be as failed, this one anticipated or unanticipated difficult airway. That another puts an algorithm into use now. In these type of cases, I think that is we normally do when the baby has to be delivered, because after it's delivered, then the patient become more relaxed psychologically and physically, clinically also, because that particular traction on the upper dermatome is released to a large extent. Just holding a mask, we have done many times. My favorite drug is always like a mixture of the ketamine and midazolam at that time, because at that time it may not going to bring the Apgar score of the fetus also to a lower level, but that is very helpful. The reflexes are intact. The patient, we always take a non-fasting patient, and rather than when you are doing this mask ventilation or just holding the mask, you have to be careful about any vomiters. So always be very careful about that particular when you are holding a mask. That's a one risk associated with that. But I think having a LMA also, second generation or third generation, will be very helpful, because these patients, if the patchy effect is there, just required a partial supplementation with the anesthesia rather than going with the tube. Securing the tube with the endotracheal tube sometimes very difficult. So these are a different situation in the practical setup, especially in the private practice. when you encounter these patients. So always anticipate obstetric patient a difficult airway. That has to be taken. You have to, whether you are coming accounting emergency, many times the patients are already draped and clean and draped, and you are encountering the patient, you have to come for the spinal. Many private setups have seen, but always try to open the mouth of the patient at least for a part time, and try to assess the airway in a rapid sequence assessment. That's also called. You must do that thing so that our life should be little safe when we are securing the airway during the section. So this is a practical scenario. Definitely, I think the message is very clear to almost everyone here that how to proceed in these type of cases. Thank you, Dr. Manisha, for your practical knowledge. And we will be, Surya and Aradhana, you keep on, compiling the questions with you. We can take up at the end of the discussion now. Okay.
Yes.
So coming to our next question, I'm asking another young dynamic Dr. Amrita. She's doing so many duties, a young mother with a young kid, and doing the running in the trains, in the metro to go to the OTs and the hospitals, and coming back, taking care of the kids as well as you're taking care of the hospital. So, right for her, a young child, Dr. Amrita, a young child of 2 to 3 years coming for elective or emergency surgery, having mild, moderate, or severe UTI on these three scenarios. So, what will be your approach in all the three conditions where the patient coming, whether you want to postpone or you want to cancel with a URC? A young kid, and you must be imagining that your kid is in on the operation table. So that's
Yes.
how you proceed.
So first of all, thank you, sir, for giving me this opportunity. This is the first time I'm a part of a panel discussion. As Naveen sir said, I think for me, it might be my nth number of pediatric case, but the mother, it is her only child. So I need to be aware of that when I give this case. So if a child comes with a minor upper respiratory tract infection, if I'm confident as an anesthetist to give this case, I would first speak to the surgeon. How is it an elective case? Can it be postponed for the next 2 weeks? Or is it an emergency, semi-elective case, emergency, urgent case? Based on that, I would take my decision and then speak to the patient attenders, that is the parents, and tell them the risks and complications we expect with the case. With there is a risk that the patient might have a prolonged recovery time in the post-operative recovery unit and everything. If it is a minor case where it can be done with a little bit of sedation, it is a little bit of just a face mask holding, and if the patient has just a running nose, which is a clear running nose, no other constitutional symptoms, the child is very active and healthy, and it is a minor case, I would then speak to the patient. If the patient attenders are clear about going ahead with the surgery, only then, if I have another anesthesiologist for backup, I would go ahead and do the case. If it is a minor case and it's an elective case. But if the child has moderate symptoms, that is, if the child has fever, the child has a very productive cough, but the chest is clear, the child has a little bit of runny nose, but it is little bit of mucopurulent discharge, running nose, then I would speak to the surgeon again and see if we can delay the surgery for another 2 to 4 weeks, because they are prone for perioperative respiratory adverse events. I speak to the patient attender also regarding this one. I will tell that waiting would have a benefit versus risk ratio I need to see, and then speak to the patient attender regarding I can postpone the surgery for a couple of probably 2 to 4 weeks, where it will benefit the patient more than because it is an elective case. But if it is an emergency case, I do not have a choice. I need to explain the family about the risks of undergoing the procedure, the risk of laryngospasm, bronchospasm, the risk of needing a longer ICU stay. Then I would go ahead and induce the patient. If it can be done under a laryngeal mask airway, then I would go ahead and do the case under a laryngeal mask airway, where I will induce the patient and introduce the laryngeal mask airway in deeper planes of anesthesia, and make sure that the plane is throughout the surgery, I maintain the deeper plane of anesthesia, give a very good analgesic, and at the end of surgery, I make sure that the patient is, the LMA is removed in deeper planes of anesthesia in lateral position. And I'll make sure that I observe the patient even after procedure for the another couple of probably 1 to 2 hours to see, because they are prone for spasm even when they are drowsy in the recovery room, retaining of secretions. So I would observe the child for another 1 or 2 hours in the recovery room and then shift the child to the ward. But if this case comes under emergency surgery, elective surgery, I would still speak to the family and probably delay the surgery for 2 weeks. Call back the patient after a week and assess the child again, reassess, reevaluate the child, and then see on how long do I have to postpone the case. But if the child is having severe upper respiratory tract infection, where the child is having a fever, child is lethargic, the oxygen levels are low, then I would go ahead with emergency surgery, considering all the risks, speaking to the attenders about all the risk of pneumonia, also post-operatively, post-op ICU stay and everything. But if it is an elective surgery, I would very well speak to the patient and family and tell them that this it is better to wait for another 4 weeks before we take up this case for surgery.
Okay, so here comes the other Pandora's box: the how to wait, when to wait, and how to do the things. So what happens now? I'm telling you, with these recommendations were of previous
Yes, sir.
generation.
There are new
Generation
recommendations now
15,
saying.
20 years earlier, these generation. Now, I think with the all the pediatric associations as well as anesthesia associations, if they work together, the period has to be reduced. See, in the children, the reactiveness, the hyperreactiveness of the airway, whenever you control the active inflammation, whenever you control the active infection, they heal very fast. The reactivity comes to a normal very fast in these type of reactivity, well, goes very fast in these type of patient. So it's always better to involve the people along with you. You are a senior in this type of cases. The senior anesthesiologists have seen over the years. See, guidelines may be saying a 2 to 4 weeks, but I think even after 5 days or 6 days, we
Yes,
have
sir.
taken up surgeries in many setups, because the hyperreactiveness of the airway is a very unanticipated or anticipated or unknown fear of every anesthesiologist, especially the pediatric anesthesiologist. One is sitting with us, Dr. Ridhima. She is a pediatric anesthesiologist. She must be agreeing with me on this part, that after treating the patient for 5 6 days, I will like to take up this case if the patient is having a severe symptoms or respiratory tract infection. Okay. So in these cases, I think whenever you are having this one treatment of this patient, apart from the counseling with the parents, I think it's always better to have a combined counseling, sitting with the pediatrician and yourself, sitting with the patient's relative. It will give you a more boost. It will give you more confidence. It will be more clarified. Pediatric surgeon, pediatrician, as well as yourself. If the three of you can sit, if you three of you can sit, I think that will the best solution. The parents will get convinced. A team of doctor can always convince the patient's parents better than an individual. So the whole things like among the communication, and I think clinically also we haven't seen the so many of the the RCTs over these things. What should be the optimal time period of not doing the surgery rather than doing the surgery. I would like to hear from the pediatric anesthesiologist, Dr. Ridhima, what her take regarding these type of cases.
Good evening, sir. I do agree with this that it's very important nowadays. It's very important to, before postman to know the reason behind it. I just want to tell, few days back we have a very new need for a TEF. So few people, if you are postponing a child with the adenoid or a tonsil, who will be having a UTI often, so that makes no sense. If you are really going to benefit the child, because most of in our region in Maharashtra we have child with fiber optic evaluation of recurrent UTI. So for that you are going to postpone it. There is no, it's not going to benefit. And I do agree with you, sir, there should be a multidisciplinary approach, and it is not about only involvement of the parents. It's mostly involvement of the pediatricians and the pediatric surgeons and a multidisciplinary team to understand where and when to take the child. Just postponing for that day doesn't make the answers. So you need to know when is the set time. As sir said, obviously, after 4 days, we all take the same child with happy faces. Ki, theek hai, abhi that day has gone. But what has happened in 4 days, I don't know. But definitely it's there. So, and
Please.
very Amrita, And
Okay,
Amrita, you
carry on,
said
carry
very
on.
nicely. It's very important to involve two pediatric anesthesiologists. Senior one is always there to help you, because whenever you are taking this case which are dicey, you must involve some senior with you. And the guidelines also say if you're taking a very high risk patient, especially a pediatric patient, two persons should be there in your OT. So that is very important. And parents, it is very difficult at that moment. Parent might agree. I will just emphasize consent is also very important from the parents, because if something happened to their child, they just forget everything what they have told to you. So you need to be very very clear to the parents. You should take your consent, and ICU backup should be there, especially there is a conflict. I don't know about other area. PICU and main ICU, sometimes they don't have their circuits and everything in the main ICU. That is usually under the anesthesia people. So you must have a backup of the pediatric ICU where you can shift the child safely in case you are required. It's not the type of anesthesia, it is the safety of the children. You might put LMA, you might put tube, whatever is your experience. But taking that decision means the responsibility of giving child healthy and happy back to the parents.
Yeah, definitely. So the message is very clear. So we have to weigh the pros and cons of the guideline, the recommendation. If the severe infection is there, definitely. And we may not be having the pediatric ICUs. They are not that common in our country. At very, very rare in good institutions, they are there. So, but at least we should be having a tie-up. When you are doing a private practice, you should be having a tie-up if something goes bad in these type of cases, where we can always shift our patients. And that consent is a very, very important, always the preoperative consent. And most likely, if the patient has a severe infection, to always like to take a video consent also, if possible. So that will give you a good, basically, or to cover. It will be giving you immunity against any medical legal. There are a lot of people around, people different mentalities. So it's always better to have a consent in a proper manner. Dr. Amrita, that was coming straight from the young mother who giving anesthesia, always give anesthesia to the pediatric patients. Now moving to the next, now we have our PG students are there, and Dr. Prakriti, she just appeared for her final practical examination, just going to become the good anesthesiologist. I think she must have learned many, many good things during her postgraduate career. So, Prakriti, I am just asking you one very thing which you must be doing almost every day of your postgraduate career, that whenever you're conveying PSC with a patient having so many comorbidities, in the evening on the phone to your senior consultant, and after when you convey the entire PSC, the message comes from the senior that you take the opinions of all the super specialties, considering the comorbidities before going forwards. And when you know that the patient's current condition is controlled and you can go ahead with the surgery, so what is your reaction and how you want to perceive it, and what type of messages you want to give to the budding anesthesiologist?
Good evening, sir, and to all the other esteemed panelists. I'm being honored to be a part of this panel for today's evening. So, sir, genuinely, from side of a PG, if I see the most genuine reaction that comes from a PG once he hears that, okay, the case is going to be postponed for tomorrow, then in that case, the first reaction that comes out is of happiness. Okay, so because when there's a list of about 15 to 20 cases to be posted for the next day, and out of that humongous list, if one case is being cancelled, he or she thinks that it's a leverage that from tomorrow I can go home half an hour early. So in that case, the most genuine reaction that comes out from a postgraduate is that he's happy. But like every coin has an other side to it, this also has an other side to it, according to me, that when a consultant says,
Prakriti, patient is your relative now.
yeah, the patient is my relative. So that is the one that is the other side to it. The other side that comes out in this case scenario will be that I will have to think about the comfort and the safety of the patient. So in that scenario, it becomes very important to understand that why is that no coming in? And why are our consultant asking for all the other kinds of references from other super specialty? So as because residency is a learning period, I'm going to learn under the guidance of my consultants. So understanding this particular thing and the anesthesia implications as well that is related to the case becomes very important. And this understanding comes very late. For us, it becomes that short moment of happiness becomes very important rather than understanding that there are anesthesia implications attached to that particular thing, and how important is the safety of the patient and the recovery of the patient. Is that surgery actually important for that patient, or the safety of the patient takes at par? So understanding the risk benefit ratio becomes very important in this case. And the second part that comes out to be learning the art to say no as well, because many a time that no also becomes very important. Anesthesia being the most sued branch after gynecology and pediatrics, it becomes very important to understand that why is that no coming. And if that no is that important, then we can also postpone the case, plan it properly, and then take up the case. But if our intensity and gravity by which we are informing the case, because we are most of the time in the evening rounds, we inform the case on phone. So once we start narrating the case, the case is having this comorbidities, and this is being implied, and this is the case that is being posted for. So the intensity and gravity by which we are actually conveying is also a very important factor, which plays a role in the way our consultant react to it. So if we think that no, it is important for the patient to undergo the surgery, then we should also play a very important part, learn from it, that why is that no coming in? Is there any guidelines or scoring that our consultants are taking into consideration to cancel that case, postpone that case? And how the safety of the patient becomes important to it, how it will enhance the recovery of the patient or optimizing the situation becomes important. So that learning phase will also help us once we are out of this guidance after 3 years. This learning is the one we are taking with us into when we are going on a private practice or going outside to practice as a freelancer. Whatever we learn right now in these 3 years becomes very important. So I guess understanding the situation, understanding the risk benefit ratio, how beneficial it will be for the patient. If my relative is on the table, whether I will go for the surgery or not, or whether I will play an important part in manipulating the things or not, how will I convey the message to my consultant? So these factors are very important, and understanding the whole implication comes out to be very important. I think from every no we can learn.
Yeah. Thank you, Dr. Prakriti, for opening your heart out. Definitely, even I also used to feel happy when the case used to get cancelled. But over the years, I think that was a transient and momentary happiness.
Yeah.
But the list is not long. I think the cancelling the case has become a more difficult one. If the list
Yeah.
only 2, 3 cases are there in that list, and you are cancelling one of them, definitely. But if the patient already see when you are conveying the facts about the patient, I think as a postgraduate 3rd-year student, you are almost complete anesthesiologist, almost.
Almost.
And I think it's a communication also. Sometimes it depends upon the PG students, how the behavior, attitude of that PG is there. Or he or she will be conveying such a manner that knowing the consultant well over the last 2.5 years, that this consultant will behave like this. So I have to convey like that, so that will cancel the case or get the case done. So I think the people who like to take up challenges, who like to be excelling in this format and getting the cases, the challenging cases done in the operation theater, those are the people who really get excelled in the later part of life after
Sir.
passing.
Definitely.
The happiness may not land you in the, the reaching to the zenith of the popularity, but the
Sure,
attitude
sir.
will definitely, attitude will always bring you best out of you later on. So definitely, you go into the discussion. You can always discuss with the consultant later on why this case was cancelled. What were the conditions that propel you to cancel this case or postpone this case? Fine. Thank you, Dr. Prakriti. Amrita, you want to add something to this? Unmute yourself. Unmute. You are muted. Amrita, unmute yourself. You are muted.
Yeah.
Yes, sir. I think over the years, what we have learned is to become perioperative physicians. So there was a time when you used to give sugars are high, we used to give physician reference. The patient complains of back pain, we give her this neuro reference. patient has a little bit of this, we give a cardiac reference. But I think over the years, the thing has changed where we have become perioperative physicians. We are able to better manage the sugars, the blood pressures. Because when we ask for a cardiology opinion before surgery, they do give moderate risk, high risk. Invariably,
Yes.
we have to take up the case, whether it is high risk, high risk. I think we
Yes.
can assess the patient better than them.
Yeah.
Definitely true. Definitely I agree with this thing because in my hospital, I never go for the opinions unless and until it's a very high risk case where we cannot manage the medicine part. Because already you have learned so much of medicine. I think no physician come to the inside of the OT to manage those cases. You are the perioperative physician, should be knowing. And I think your medicine knowledge should be good. Keep on refreshing the knowledge, even you're in private practice. Keep on attending the webinars or the mini conference, CMEs, or any education part. You can always read a book also. If you get a particular case done, you can go through that case in the evening, read about it. Your knowledge can always get refreshed. Thank you, Dr. Amrita, and thank you, Dr. Prakriti, for such a good attitudinal, development and shift of the younger generation. And coming to the perioperative physician, I think another postgraduate student, Dr. Shrishti, who has taken this profession by choice because she was so much impressed with the ICU working as a resident that she opted for anesthesia by choice. This is how the things are getting, built up in our country. So, Dr. Srishti, just like talking about the perioperative physician role, so a non-epileptic patient coming to you with well controlled on anti-epileptics and took the morning dose of anti-epileptics also along with the pre-medication. But when you are going to take up that case, just before taking up the case, the patient developed some seizure. So, what is your path of taking anesthesia to this patient? How are you going to tackle this?
First of all, thank you, sir, for making me a part of this YUVA Clip series. Like now, let's coming back to the case. Like as you have stated that the patient is having active seizures. So before proceeding, our first priority should be to stop the seizures and stabilize the patient. We should always remember our basics like A, B, C, and like for airway, we should see whether the patient is having a patent airway. We should do the suction and provide supplemental oxygen. We should assess breathing, and if required, we should give assisted ventilation. For circulation, we should quickly check for the vitals, and along with that, we should establish IV access. Here we can also take help of the IV medications like lorazepam, diazepam, or we can take anti-epileptics like phenytoin or sodium valproate. Now, if the seizures are not getting under control, or if they are persisting for 30 minutes, which is also known as refractory seizures, we can induce the anesthesia.
We will talk just about single episode, single episode of seizure, not the refractory one. It will be complicated. Single episode of seizure, the patient developed just before shifting to the OT.
Okay, so now after we have controlled the seizures, now decision making time comes. So as stated by Naveen sir, we should always treat each and every patient as a relative. So this decision is based on whether what type of surgery it is, whether it's an elective surgery or it is a emergency surgery. Now first let's continue with the elective surgery. Ideally, we should postpone the surgery for up to 24 hours so that we can evaluate what is the underlying cause, and we can look for all the parameters. We can see what are the triggering factors, whether it's an electrolyte imbalance or it's an alcohol withdrawal symptoms, or sometimes it happens that patient gives a false history that, okay, I have taken the morning dose of my medication, but once we investigate or once we start digging up the things, we come to know that, okay, they have not taken today's medication. They say that डॉक्टर ने कहा था खाली पेट रहना है, तो फिर मैंने दवाई नहीं खाई थी, या फिर ऐसा something like this. So ideally, we should postpone the case for 24 hours, and once everything we have done all the workup, we can post it for coming days. But in case of an emergency situations where it is a life-threatening situation where we have to take up this case, then we should proceed, but with all the cautious. We should keep in mind that what agents we have to use for induction. like we should induce with propofol and thiopental, which are safe, and we should avoid ketamine because it lowers the seizures threshold. And for muscle relaxant, we should avoid atracurium or cisatracurium because they release histamines and then it also triggers the seizures. We can use rocuronium or vacuronium. For sir maintenance also, we can go for Tiva with propofol or isoflurane or sevoflurane. They are good. So for my means, these are actually
So you have given your revisions or what you are doing. I think that's a good revision
yes,
of
sir.
the syllabus.
Actually,
But I say if the patient wants lower limb surgery, will you like to go for the spinal in this case? With
sir,
emergency lower limb surgery, emergency debridement, or something emergency happening, or emergency, inguinal hernia, obstructed inguinal hernia, will you go for the spinal in this case? The active scissor just happening.
sir, if it's an active seizure, no, sir, I will not go for spinal because my first priority is to control the seizure.
Yes, because the activity has started from some focus in the brain. So it's not recommended to go for the spinal in this case at any cost. If the surgery is the emergency surgery, go for the GA because that is the what the brain activity will be. Whether you will add, you can add anti-epileptics also to this patient. You can escalate the doses or you can add a new one apart from whatever the patient was taking. Get the things done under GA. That's more important. Naturally, if the patient is having a seizure for elective surgery, that's the right answer. Because if even without surgery, the patient is having seizure, that means maybe some psychological component, some anxiety component, stress of the thinking about the surgery, the patient can have the seizure. So what you can very well imagine that post-operatively, the seizure will be more detrimental to such patients. So it's always better to explore the cause or to just increase the dose or enhance the dose and talk to the neurologist, oblique physician, what is the best way to go forward, discuss with them and discuss with the patient and the relatives that this is the scenario. I think
So
we
we all must have heard there's a famous saying that an anesthesiologist is the captain of the ship. So it's in our hand that we want to sail the ship in which direction. So I just want to say that for to conclude that in a nutshell, we should remember four goals. First is we should not panic. Second, we should always see that our priority is to stop the seizure because we now later we'll get the time to decide that whether we want to proceed or we want to postpone. And then meanwhile we can go for pre-operative evaluation, like what are the triggering factors. After that, third goal can be that now we have to see what are the surgical consideration. Is it an elective case or I can postpone, so that I can postpone it, or it's an emergency, it's a life threatening one. And then later the last goal is that post-operatively also I have to make sure that there is no reoccurrence or what are means, so that patient is in a good hand and they should be in safe.
Yeah. And immediately post-operatively, as soon as the patient is fit or conscious, you can always administer the oral if the patient is taking the oral anti-epileptics, or if you have used injectable, I think it's better to have a cover of the injectable so that the patient should not have a post-operative seizure because the stress is too much. The patient surgery is there, the pain, the other factor, the vomiting, so many other factors are there which can precipitate the seizure activity in this state. Thank you, Dr. Srishti. That's a good way. You are preparing very well for your postgraduate examination also.
Yes, sir.
This is how I think our discussion went with all the good panelists, young panelists. Now, I like to ask Surya and Aradhana, have you both seen any questions coming up which we should discuss?
Yes,
Apart
sir.
from
Sir, there's one question regarding Dr. Vinita's case. If the patient with post-PTCA or CABG status, what are the guidelines for stopping antiplatelets?
what are the guidelines for stopping the antiplatelet in the post-CABG?
Yes, sir.
Okay. See, now again, I think that was a very, very important part. I can answer for Vinita. Dr. Vinita, may I answer or you want to answer yourself? You want to answer. Okay. I will give the chance to you first. Okay. Unmute yourself. Unmute yourself. And that's a good, confidence. I like this confidence. Yes,
Sir,
Dr. Vinita.
actually, I wanted to add that thing into my discussion, but I thought that was not the major point to be discussed. It was whether the cardiologist is there, is not there, how to proceed with the case from the anesthesia point of view. So here, regarding continuing the dual antiplatelet in a patient with post bypass or post stent placement, there is something known as bridging therapy, wherein we
Bridging
stop the
therapy.
dual antiplatelet. We start the patient on low molecular weight heparin or unfractionated heparin based on the renal status of the patient. As you have told, there is conflicting guidelines whether to stop clopidogrel 5 days prior, 3 days prior. It all depends on the type of surgery also, whether it is a high risk surgery, intermediate grade surgery, wherein if it is a semi-emergency situation, we can stop 3 days prior to the surgery, go with the bridging therapy, go ahead with the surgery, and then restart the dual antiplatelet 24 hours prior post surgery. And if it is a high risk surgery, then it is better you stop it 7 days, 5 days prior, go on with the bridging therapy, and then go ahead with the surgery. So here, sir, many a times I have been seeing in recent times, even though I mention it on the PAC paper that consider bridging therapy in so-and-so patient, there are no proper orders from the physician. So in such scenarios, sir, how to tackle the situation? Because patient has abruptly stopped the antiplatelet or anticoagulant 5 days prior, 3 days prior, coming for an intermediate grade surgery. These patients have a high risk of having peri-op MI. So how to tackle such situations, or wherein patient is coming as a on a daycare basis, admitted in the morning. So we have no idea whether the bridging therapy was started or not started. So how to proceed with this, sir? Apart from pre-op counseling, consent, a proper return informed consent, apart from that, what can be done, sir, to tackle with
Yeah,
the scenario?
that has to be discussed in a wholesome manner with the attending surgeon also. Because see, the surgery is there. You are not going to be taking an entire responsibility for whatever the patient has done or patient has stopped abruptly. It is not your fault. But you are now facing a uphill situation where the decision has to be made. Decision cannot be made by you alone because that in that case the surgeon has to be involved. That this is the case scenario. These are the potential risk complication associated with this scenario. So how to go? First, you discuss with the alone with the surgeon. So whatever the level you come at in getting the surgery done or not, then you first have to take into confidence both of each should be on the same plane at the same level. Then you can talk to the patient that stopping this thing it can lead to complication. The alternative is that we continue for some time and we do the bridging therapy, and that will be more important, will be more safe to you. So that you can always, I think it's very easy to explain to the patient with the consent of the surgeon and your consent together. That's the only way to go forward. Don't take entire responsibility on yourself. You involve the surgeon. Tell the, because surgeon can understand this thing also. ऐसा नहीं है. Because every surgeon knows that this is a patient with a CABG and a post-end placement PTCA, and these are the complications. Everybody wants to be, free from the medical legal implications later on. So you can always tell in a way that the medical legal implication, highlighting them that these can occur if we are going ahead because these are not according to guidelines. And if the emergency surgery is there, I think you have to go ahead again taking a consent from the patient along with the surgeon. Then you can go ahead with the surgery as required for the emergency surgery. For elective, this is a must. Any other question,
And,
Dr. Surya?
yes, sir. And one more question is assessing the patient with apart from echo, clinical evaluation with the functional assessment, metabolic status assessment, which will be a good predictor for the cardiac performance.
Yeah, definitely. So we could, because in the discussion, we were more about the clinical precision, how to go about or not, but we were not discussing those things. I think those are good points. That is fine. What else?
And cardiac patient with NT-proBNP of level more than 900 planned for hysterectomy, sir. So should we optimize the patient or should we take under high risk in cardiac, the compensated cardiac failure patient?
See, cardiac patient in compensated cardiac failure,
Compensated cardiac failure.
hysterectomy. I think you have to optimize this patient. You have to optimize. You cannot just go ahead with taking the risk whether you are a cardiac anesthesiologist or not. In these type of patients, you have to take whenever you are going to cancel a case or postpone a case, always take the attending surgeon, gynecologist into consideration. That together you have to do this thing. You should be having a knowledge about this thing that what this level of pro-BNP means. Okay, and that I think has to be explained to the patient, the relatives, This is very important. Emergency surgery, though, I think we always have to take challenge because we are always under the cover of medical legal purpose. Under this type of patients with a compensated cardiac failure or elective surgery, not recommended. You have to get it done with the consent of the. You have to properly evaluate and optimize this patient to be taken up for hysterectomy. Hysterectomy is an elective procedure.
Yes.
Arun, you want to say something?
Yes, sir. Yes, sir. May I, sir?
Yeah. Yeah, please.
Yeah, since I'm in a cardiac institute, sir, since 10 years, most of the cases, our cases are cardiac cases with poor EF, ejection fraction. A single value of NT-proBNP never has a value. Mostly clinical optimization is the best. And NT-proBNP is age-related and many false positives may occur. It is for 60 to 75, it is 900. More than 75, it is 1800 is normal. So single value does not make any.
But it's written there, now compensated cardiac failure.
Yes, sir.
That means the
Clinical
patient had a history.
Yes.
Patient had a history, and see, the cardiac failure can exaggerate or precipitate any times in these type of patients.
Definitely, sir.
Clinically,
will be better. Thank you, sir.
Yeah, I think evaluation is a very, very important thing. Any other questions, Surya?
Sir, I am having one doubt regarding pregnant patient with a difficult airway, like anticipated difficult airway with the failed spinal suspecting. Is a plan of involving epidural also in those patients will be helpful because the spinal may also fail actually. So if it is there, epidural will be another good option to consider.
Surya, what happens? I will tell you the reason. Because in a practice, you don't get time for the epidural. Epidural, in the fetal distress, we're talking about emergency, LSCS.
Yes,
Putting an epidural itself involves a 15-minute, 20 minutes, which even the surgeon, gynecologist, obstetrician, they will not be able to tolerate those 15, 20 minutes. And it can be a legal problem also because they will say that your time taking has led to the poor fetal outcome. So it will be a very, very dicey situation for the anesthesiologist to put epidural in those cases. Elective is okay. If you have already inserted a painless labor, you have inserted epidural, and that case lands in fetal distress, then it's okay. But ideally, on such patients, spinal is the most important part, not the epidural part here. So you have to avoid epidural in these cases. And an emergency, and 99% cases, we go for this one, a spinal only in this type of fetal distress. Ali has raised the hand. Ali, you want to say something? Just wait. I have to see. Yeah, Ali, I have to unmute. You have to unmute yourself.
It's a very good discussion that's going on, sir. Good evening, sir.
Now, you want to add something? Your voice is not audible, Ali. You switch off your video and then you speak.
If we are telling a genuine reason to a surgeon and
Ali,
they trust us, they will agree with us, sir, for postponing a case. Regarding postponement of a case, simply agree with us if we tell a genuine reason, sir.
Yeah, you have to be very genuine. I think the anesthesiologist, 99% of the
time
anesthesiologists
they will agree with us, sir.
Yeah, we are always genuine people. That's why we are doing the discussion also very genuinely. So we are genuine people. That's
nice
not
discussion.
an issue. Yeah, thank you, Heli. Manisha, you want to add something? Unmute.
So this is regarding that question asked by Dr. Surya, very typical, like in an elective case. So we had this case which I had presented also, a chondroplegic trough for electives. Actually, she was not an elective. She was presented to our hospital after a post-spinal cardiac arrest status. So probably post-spinal, she had an high spinal where she had arrested. She was revived. But unfortunately, in that setup, nursing home setup, she was not delivered, which is the protocol, ideal protocol. If there is a status, baby fetus should be out immediately in the resuscitation guidelines also. But then she was not resuscitated, and in the panic situation, they had referred the patient to our center. So when we received the patient, she was absolutely okay. All the hemodynamics was normal, everything was normal, fetal distress was not present. So we planned to take it electively the next day after settling her because everything was all okay. In that case, we had put in spinal plus epidural. because we anticipated that difficult airway is there and plus difficult spinal also in achondroplasic drop. We expected difficult spinal also and erratic spread of the spinal drug. So in that we had put in a CSC.
Yeah, fine. I think that's the message we have given. In elective, we can go for the epidural if the facilities permits, if we have got the time, everything we can go, and it will always help us in tiding over the failed spinal also, but not in emergency because we encounter so many cases in our daily life like that.
Yeah.
Bhumika, just you want to say something? Be very quick. Huh? So we move to the next. Those 2, 3 questions are there. Bhumika, you want to say something? Unmute yourself. Unmute. Yeah.
Yes, sir. In a very short, I want to convey only one message. The pre-operative evaluation and pre-operative patient-doctor relation helps a lot in such a situation. And in my experience, I have never figured out the difficulties in conveying any messages whether it is postponement or a cancelment. I have done multiple times, like in private setups, and it was never an issue with a surgeon or with a patient. So I would convey the only one message: good communication and the consent and the explaining the facts with the patient and the surgeon helps a lot in this situation. So thanks a lot.
We have
Yes, sir.
because what we feel the attitude of anesthesiologist, if it's a good and friendly, it is taken better by every surgeon. They know that this anesthesiologist is going to be a very helpful for their patient. It will help a good team. I think that is almost 90%, more than 90% surgeon understand if the anesthesiologist attitude is very good, skills, communication skills are good, method is good. I think that anesthesiologist earn a good reputation and a good, a goodwill of the surgical fraternity also. So, any other question, Aradhana and Surya? Is there end
I
of chat
have a
box?
question from Dr. Kavita. She wants to know, are there any general guidelines, means society guidelines for postponement or cancellation of surgery due to anesthesia-related causes? As the percentage of rescheduling of surgery is an anesthesia quality indicator.
I think as such, there are no guidelines on the cancellations of or postponement of the cases. I think this our panel discussion will definitely boost up the formation of these guidelines. Anesthesia-related issues, say, just like that in elective surgeries, just like that patient had a seizure, but to postpone in the pediatric case, severe infection, postponing the get case. Okay, and I think where the patient's life is at stake before going for the anesthesia in that patient, it's always better to postpone that case, which can give us time to optimize the patient. And where we think that the patient is not going to be optimized, even by taking time, even by taking a treatment, and it is not under our capability or capacity to administer anesthesia in that case, I think that case should be referred to a higher center. So as such, there are no guidelines, but anesthesia-related causes are there. A difficult airway I encountered just day before yesterday. A difficult airway was there. Even I had that to put up a question because that commandos, not commandos, she had a different operative procedure, and when I encountered, it was me only who was two of my anesthesiologists alongside with me. We had all the things with the fiber optic also. We could not visualize properly because there was only a chink of 1.5 mm. I think the maximum 2.5 mm tube could have gone inside. Patient was breathing fine, but under got ventilated also. But you can't push a tube there. You can't push a tube in that airway with a tight glottis because the fibrosis of the previous surgery of the tongue, there was a fibrosis around epiglottis and a glottis. So in that case, the surgery was very elective, like tympanomastectomy, and there was no recommendation to go for the tracheostomy in that case. For such a procedure, it is not recommended. But it should not be a surgeon or an anesthesiologist's ego to go forward to securing the airway. So I straight away put up my hands that in spite of my so much of experience in my life, I'm not going to go ahead with this case. It's not feasible for me, not feasible for this setup, and the surgery is very elective type. If the surgeon can do it under local and without intervention of the GA, because in a local also sometimes the surgeon may ask you can give GA, you have to give GA, the patient is not cooperating. So that is also not recommended in this case. So I put up my hand that this is not for me. This case I cannot handle. So you have to be very, very, you don't have to achieve a glory in going ahead with these type of surgeries. You have to postpone these cases, or you can refer them to some higher centers where the patient can also understand that the patient difficult. I wrote on the file, on front on the file, a very difficult airway, non-visualization of the proper glottis, because only the chink was visible even with a fiber optic bronchoscope. There was so much of fibrosis of the supraglottic area. Any other questions, Surya?
That's all, sir.
Yeah, there is somebody written pro BNP is not a good predictor. Definitely. But I think in that discussion, it was mentioned a compensated cardiac failure. So there must be other parameters also on the basis of which it was termed as a compensated cardiac failure. So we have taken into account to all those factors because that was a part of discussion. Anything else left?
No, sir. No other questions, sir.
Really? So our panel has answered almost every question in a very good manner. I think we should be proud of our panelists. They have done a wonderful job, and a young panelist, and right even two are PG students only, one they're just passing out. So this was a good thing. So our time to question has come. Sir, is the spinal drug we have to follow and scroll? Sorry for that. Is there any chance for delayed or partial because it was not kept in freeze? No, spinal drugs we don't keep in the freezer. The spinal drugs we don't keep in the freezer. Rather, at the room temperature is recommended. I think ambient temperature of the room is good enough for the any either sort of going for the ropivacaine or a bupivacaine, whatever you are going to use. But whatever the things that in winter season, the ambient temperature also decreases. The cold drug takes a longer effect. You can't heat the drug anywhere. I think just take in the palm for 2-3 minutes, just rub in the palms. I think that temperature will be good enough. The glass is a glass vial, that the temperature decreases. It has a good effect. That is what we are going to have. Dr. Madhuri wants to convey something now. Dr. Madhuri.
Yeah, I made a wildcard entry. Just my one question to all the panelists, that are cancellations and postponement of surgery always the anesthesiologist's fault, as is always depicted everywhere? So who can answer this?
No, no, see, I can answer on their behalf also. It's
No,
not about.
I just want to add here that it's not that. What I want to add is that it is also the planning, the planning of the OT list, which is very, very important. So the surgeons have to prepare the OT list systematically and in a way that they will finish in the scheduled OR time. So it is found in many hospitals, the OR lists are not planned properly. All the waiting list, all the patients, if they are posted in the list, then the time is not sufficient and the cases are cancelled.
Yeah, definitely. This
So
I
it
agree
is
with.
not, so planning a proper OT list is also very, very important.
Yeah, it also depends upon the type of surgeon you have got. A person may take you 3 hours for laparoscopic cholecystectomy. Other surgeon may take 15 minutes. So it also depends upon those type of logistic, the skill of the surgeon, the time of the OT cleaning and preparing for the next OT. So many logistic issues are there. And many times it's not the anesthesiologist. Many surgeons, they want, see, somebody wants to say that I have to go to some function. So better to keep this space tomorrow. So it is sometimes like that also. It's not just the one person. We are morely dealing with our fraternity here, that what are the common reasons and how can we minimize that postponement and cancellation of the cases from our side. So that tomorrow, even with the documentation on the file also, whatever the cases we are postponing or cancelling, the documentation has to be complete in all the sense. That is very important.
Actually, we are absolutely right. We're discussing the other aspect. But for the youngsters, I can say, you can always tell to the surgeon, sir, going by your list, if we get all the cases done, it will be 9 a.m. tomorrow. So please keep on working. Dr. Madhuri is right. At times they keep unrealistic lists. There are 12 patients. So you tell them, sir, I'll get all the cases done. But you take care of the sisters, you take care of the autoclaves, and you take care of the other aspects. So please, then they will realize that they have to keep a realistic list.
Yeah, that's true. Realistic has to be there, but in many setups, even the lists are because only one or two patients are there. Sometimes there are in the many busy center there are multiple lists. So I think that is an issue. Again, I will go by that thing that in the same unit, one surgeon is very fast, one surgeon is very slow, and the OT gets entangled with that the slower surgery and just like a rate limiting enzyme of any chemical reaction that the space of the surgery is discussed by the decided by the pace of that surgeon, the skill of that surgeon. Moreover, I think the timings, because the staff timings are also there. I think the normal working time of the institution, suppose it's a 8 to 4 or a 9 to 5, whatever the institution timings are there, you have to keep the list according to that timing, because you may not be able to get the good amount of workforce after that timing. After that timing, people just move out, and you're left with very small manpower. And in case of any emergency catastrophic situation, it becomes difficult to handle elective surgeries in that. So that's true. So these are factors. Before asking any question, let us felicitate our panelists first before moving forward, because already it's 2 hours. It's a good discussion. I will like to take opportunity to thank all our panelists here. So my screen visible? Visible to everyone? Okay. So
Yes, sir.
Dr. Karthik. So Karthik, so thank you very much for being part of this. You are the opening batsman. Thank you for the part of this panel discussion.
Thank you very much, sir.
And Dr. Manisha, thank you
Thank
very
you,
much
sir.
for the part of this session, your certificate.
Thank
Then
you,
Dr.
sir.
Arun. See, everywhere ISA number is written. This is the norm we take. We don't hire any non-ISA member in this discussion. So ISA number has to be there. Then Dr. Vinita, so
Thank you, sir.
your debut today in the academics, even within
Yes,
the
sir.
private practice. Okay. And
Thank you.
Anil, you keep on doing good work, active work. You are doing a wonderful job.
Thank you, sir. Thank you so much.
Thank you for being part of panel discussion. Bhumika, you are always as enthusiastic and very enthusiastic about all the clinical discussion as well as the conduct of the cases. Thank you, Bhumika. And
Welcome, sir.
Amrita, I know that you are very much, I can see your enthusiasm from the young child, and that's why that question was given to you only.
Thank you, sir.
Amrita, for that.
Thank you,
That's
sir.
And Shrishti, third year PG student, she's doing very well. Her passion is anesthesia. So thank you, Srishti, for being a perioperative physician in this discussion.
Thank you, sir.
And Prakriti, she has just appeared for examination. So thank you, Prakriti. And remember to send your degree and registration certificate of the MD so that you can be converted to the LM also.
Thank you so much, sir.
And Surya, as well as our Aradhana. Aradhana is a PG student of
Thank you,
Dr.
sir.
Nivita Pani. Dr. Nivita Pani was also giving congratulations for her role today. So thank you to
Thank
both
you,
of you, Surya and Aradhana. You also
Thank you, sir.
actively participated in this. I think very much needed also.
Thank you, sir.
That diabetic question, that diabetic children, hypertensive, whatever the comorbidities are there, always give them priority in the first. Yeah, Dr. Manisha, you want to add something?
Yes, sir. Actually, when you gave us this topic of cancellation and postponement of cases, so I had gone through a study conducted in AIMS. It was a prospective study conducted in
It was
2009
done
to
2 years
11.
earlier. 2 years earlier it was
Yes,
there.
sir. So that says out of the 30% cancellation of cases, 60% was because of lack of availability of the theaters, maximum time. And only 10% is medical reason. And out of that, hardly 5% was due to anesthesia causes. So we are not the root cause of cancellation or
No,
postponement.
that was done by the anesthesiologist.
Yes.
So it was I have a bias. The bias was not removed from there. So I don't agree with that. That also from a topmost institution study. So or whatever the one institution study. So if you are multi-center study, you will.
I have to say something. We do a quality indicators every month, like the rescheduling of cases, cancellation of cases. And the cause for cancellation of rescheduling of cases because of anesthesia is Hardly any. I think it is mainly because of the surgeon. It is because of the patient coming to the getting admitted delayed or insurance issues. Those are the things which are reasons for cancellation. I think due to anesthesia over the years has become less. I think we are more taking up more high
That's why
risk.
we kept this topic. Now, this recording will be shown to every surgeon, every orthopedician, every gynec that how we are going about it. And it's
Actually,
not
yes,
about
in private practice, anesthesia related delays or postponement is very minimal. It is more of TPA. Most important nowadays in corporate practice is insurance.
Yeah, that's true. That's true. That's with a new thing developing with the Ayushman and the TPAs. When approval
Yes.
comes, only then we take up the surgery.
Yes,
So I think
yes.
that is the wrong precedence coming up in the nowadays present scenario. So Dr. Vinita and Dr. Prakriti just speak, and then we will switch off the thing.
A similar study was also done in our institute for the postponement and cancellation of surgery. And out of 3,000 surgeries that were done in a year, it was found that 12% which got cancelled, and majority of one was because of the preparation and the OT preparation, the lack of equipments. And us as an anesthesiologist cancelling the case played a very lesser part, contributed a very lesser part. And it was divided into both the patient factors, the surgeon factors, and anesthesiologist factor, and we didn't contribute that much. So similar study was done almost around 3 to 4 years back in our institute as well. Under the guidance of the HOD back then, it was done in our institute as well.
Thank you, Prakriti. Anybody wants to add? Yeah, Vanita, Dr. Vanita.
Sir, this is not regarding the postponement and cancellation. This is a message to the youngsters out there that you shouldn't be heroic in handling difficult airway cases. You should know what you're capable of and what you're not capable of. So it is okay to cancel or postpone the case. Ask for a help when required, rather than being heroic and going out all there and then landing in a soup.
Yeah, true. That's absolutely true. That's what I send in between also. Don't
Yeah.
work for the glory. Don't work for the glory.
Don't
It
work
is
for the
better for the patient safety. Even at this age also, at this experience, not the young, this age also, not any young only, even the senior people also, they should not take it to the ego that they have to get this case done themselves. If the patient is not under their capabilities, capacities or skills, it's better to be, cancel that case or just keep your hands up. So it will not affect you. It will not affect anything, but patient will be saved. Yeah. So anything else, Dr. Madhuri, you want to convey finally as a program coordinator for this YUVA clip?
Yeah, as a program coordinator, I think it has been a very different kind of experience to coordinate with young minds and young hearts. And the topic was a hot topic, very interesting, not only for us, but also for our surgical colleagues. And our panelists have really done very well. Yes, Dr. Vinita?
Madam,
Huh?
thanks to you, madam, for being patient with us. I couldn't thank you when I was answering my
It's a
question.
compliment.
Thanks to you for being patient
Yes.
with us, especially
A
me.
good compliment.
Yes, yes. And
That's
I think
good.
it's a very innovative thing. The YUVA clip, having all young minds discussing here, it's a very innovative. And I'm sure this will go a long way.
Yeah, yeah. Every month we will have a young
Thank
YUVA
you.
clip.
Thank you, sir and ma'am, for this opportunity. I think it is the first time for most of us here. We do not
And we
know.
try to give the first timers mainly. First timers. I think everybody came with a panel discussion for the first time only. They must have presented somewhere as a speaker, but as a panel discussion is the first time for many. Almost everyone.
Yes, sir. Yes, sir.
Yeah. Dr. Naveen, sir, you want to say something to the youngsters before we switch off the class?
So, dear UIScians, Dr. Bajwa must have told you, but you are all cordially invited to participate in your own national conference, the fourth Yuva ISACon, which is going to be held in the last weekend of April in Hyderabad, Telangana. So, as you all know, Yuva ISACon, the speakers are less than 40 years of age. And younger people like us, numerically more than 40 years of age, are chairpersons. So it is your own conference, specially designed for you, that so that you can be the speakers, everything. And there is other activities also like art and literary and cultural. It's purely your show. So join in large numbers in the 4th annual national conference of YUVA ISA at Telangana, Hyderabad. I think it is 25th, 26th, and 27th April 2025. God bless you.
So going by that, I won't say chairperson. We will say people like us are cheerpersons. So
Thank you so much,
we're
sir.
cheering you up, cheerpersons. Okay. So I think now time is almost 2 hours, 12 minutes. And we should say goodbye. And it's a very well conducted by all the panelists. Thank you everyone for being a part of this innovative first YUVA clip. And I request you to be part of every YUVA clip coming up in the next time, the next month with the new faces. So you are the pioneers. You're the first team, 11 of you, the cricket team, the hockey team. So 11 of you were the first timers. So next time we'll have another new team now. So we
Thank you, sir.
always.
Thank you so much.
Thank you, seniors, and long live ISA.
हाँ, पहले ही बोल दिया long live ISA. Long live ISA.
Long live ISA. Long live.